for being here. And while they pull up the slides, I do want to tell you how good it feels to be in front of people again and to be able to look at faces and do this interaction in person. It's just not the same thing to see 100 faces on the computer screen as it is to be able to be in front of you in person. So thank you for being here. I really appreciate it. So think of my session as a continuation of what the gentleman from Philips just talked about. It's just such good timing for me to talk about how is artificial intelligence leveraged for augmenting human intelligence, right? I have a feeling that we don't talk about the importance of artificial intelligence and human intelligence working together in unison. And I think what I gather from all of the questions that I've been hearing since morning, which were like the ones that you've been asking and quite a few others, is that within healthcare, there is a significant opportunity for us to look at how these two should coexist and work better, right? So that's why I'm going to talk about how digital health solutions augment critical human decisions in healthcare. But before I do that, let me tell you a little bit about United Health Group. And the reason I included this slide is because we have a booth at the ground floor, and since yesterday, all of the questions that we've been getting are more about the company itself. So bear with me while I spend a few minutes just telling you about United Health Group. We are one of the largest healthcare companies in the world. We are Fortune 5, about $280 billion in revenue. Last year and this year, we'll be easily surpassing the $300 billion mark. There are primarily two businesses that we operate in. One is United Healthcare, which is our benefits arm. So benefits essentially means we are the largest healthcare insurance company in the United States, right? So we are the insurers for people who work in companies. So if you have an insurance through your organization or through your company, then you know what I'm talking about, right? So that's one line of business. The other line of business is we work with the government to provide insurance to people who are above the age of 65. So for example, they call the Medicare population. And we also work with the government to provide health insurance to people who are, say below the poverty line. So people who can't afford insurance themselves, right? So we are the largest healthcare insurance in the United States. That's United Healthcare. But Optum is really our services arm. Optum not only works for United Healthcare, Optum works for every large healthcare company there is in the United States and across the world. These could be payer companies, these could be hospitals. Optum runs its own emergency care centers, small hospitals themselves. So we have physicians on board. Think of us as, when you think of healthcare, there isn't any aspect of healthcare that we as United Health Group do not touch. Optum RX is our own pharmacy benefits organization. You put all of that together, we essentially represent a very large pie of the healthcare industry, not only in the United States, but across the world. If you guys have any questions as we talk, just feel free to raise your hand and ask. I don't want to necessarily wait till the end of the session, right? So just feel free to do that. With all of that scale behind us, what are some of the biggest problems that we are looking to solve? In all of my talks, when I usually ask people the question that where do you think artificial intelligence can be leveraged in healthcare, what do you think is the most common answer I get? Replacing doctors. Or better said as disease prediction. Predicting a heart attack, So no surprises. I mean, the most common answers you would get are, oh, artificial intelligence can predict diseases or it can detect diseases. But then I ask the question, well, then what do you do with it? And they're not very good answers to that. Yes, models can predict diseases.
Take proactive action.
Proactive action is one of them, of course. But diseases obviously are important. You see that here as improving our overall health outcomes, in which artificial intelligence gets leveraged. But there are a whole lot of other areas. For example, improving the experience of the people who work with us. And that's not only limited to healthcare companies, that's true for every company. So why do we not talk about that as much when we are talking about healthcare companies? What about people who call up our contact centers and have to wait to talk to a person? What about people who submit claims and don't necessarily have good insight into when their claim will get processed? How many of you here have had a bad experience with a call center? Or how many of you here have had a bad experience while going through a claim submission process with, it could be a life insurance company, it could be a PNC insurance company, it doesn't matter. But I'm very sure that you would characterize that as one of the most frustrating experiences of your life. Isn't that an area where artificial intelligence can help? I think so. Another area is improving clinician well-being. During COVID, we all saw what kind of pressure the doctors, the physicians faced, the healthcare system faced. It almost crumbled, not only here, but across the world. Why did that happen? What can we do to leverage the healthcare professionals that we have and spread them over a larger percentage of the population? Can artificial intelligence help with that? Improve accessibility? Why not? These are some really relevant and hard-hitting areas where healthcare and artificial intelligence can go together, right? That's where Optum comes in to be able to power the intelligence to be able to solve these problems, right? This isn't a sales slide. The only reason I included this here is to talk about the $3.5 billion investment that we have going into research and development every single year. I talked about us being a $300 billion company. I talked about us being one of the largest healthcare companies, not only in the United States, but in the world. There are about 240 million lives that are impacted because they work with us. I already mentioned the investment that we put in. Now, if you put all of that together, you would think that we have everything to be able to make a tremendous impact on how healthcare operates. We have the funding, we have the resources, we have the data. A lot of the people earlier during the day today talked about the challenges with acquiring data in the healthcare space because they are not themselves generating that data. We are the ones who are generating that data, we own that data. We don't necessarily have challenges with acquiring data. Talent for us at our scale isn't necessarily a problem. Our data scientist team in India itself is about 1,200 people strong. So with all of that, one would think that we are perfectly positioned to be able to crack open the nut and make a real difference to how healthcare gets done.
So Anupam, one part that I see missing in this whole thing is it's all data and information, right? I'm missing the word knowledge.
Yes.
Yeah, and I come from that word, like trying to make sense of all the knowledge that exponentially growing by some measure, doubling every 20 days.
Yeah.
So how do you make sense of it?
Let me come to that.
Suresh, he gave me some weird answer. So I want to know, what are you guys doing? And you guys can move the needle investing money in that, like converting knowledge to practice.
Excellent question. Hopefully you'll get answer to that question in my subsequent conversation, in my slide.
I'm going to go to the Dr. Reddy's part, but I'll speak.
Sure, let's do that. So I'm going to take a segue here and go back to saying that you would think that we have everything to be able to crack that nut. But a lot of companies have that, right? What are some of the biggest challenges that are facing our data scientists today? How many models do you think actually make it to production? Does anybody want to fathom a guess? There's been a lot of research on it. How many models actually make it to production from just being experimental to actually being able to go and make a difference? How many models, what percentage of models do you think that is? 1%, 2%, it was probably true 3 years ago, but it's gotten better. Then what are some of the other estimates? 20%, 25%. I think what all of you are saying is that most of the models that are built do not make it to production. I think we can all agree to that. If you want to put numbers to it, Gartner's, this particular number that I'm quoting is from 2020, reported that 80% CIOs that they talk to are just still experimenting. 20% say the models are actually in production. Similarly, McKinsey says that 88% did not progress. I'm just coming off of a Gartner conference, so I know that these numbers have gotten better. But even today, in their latest research, Gartner states that 50% of the models never make it to production. And that's true for us as well. We've been in this space for a decade, and we've gotten significantly better over a period of time, and that's what I want to share with you, that where do we think there is still a scope to to be able to make a difference in this space. Here is another quote that I got from the same article. By the way, this article comes from the Analytics India magazine. I thought it would be a good tribute for them to, for them to getting all of us together. All of this is coming from an article that the Analytics India magazine published in 2020, and the name of the article was "Why Don't Models Make It to Production?" All of you have been talking about how to make a really good model, how to get better results, how to get better accuracy. It's an extremely important topic. Talked about a lot. How many conversations have you been in which people talk about how to take more models into deployment? What are the constraints there? Look at what the analyst says in the last statement. People who are building the model often struggle with architecting a solution for end-to-end automation pipelines. How often do you hear this term end-to-end in your day-to-day jobs and roles in technology? Whoever wants to talk about automation wants to talk about end-to-end. What does that mean? There was a question earlier today in the first session, in your session, that made a very important point about having a human in the loop. Is it the human in the loop or is it the machine in the loop? Who's in loop here? When we talk about automation, why do we want to replace doctors? Why do we want to replace human intelligence? I think it's human intelligence and machine intelligence has to be in loop with that, right? I see a few heads nodding, so I hope you guys agree with me on that. So when I began to draw this down, and I started thinking about this a few years ago when we were working on operational problems and we were not able to get a lot of models into production, for the simple reason that I'm sure all of you have faced with. Businesses, particularly in areas like healthcare, are usually not bad, they're risk averse to be able to take new technology into production. There's obviously a lot of regulation that prevents it from happening as well. But I think where everybody is focused on is the complexity of the decision that you're trying to model. It could be a radiology conversation, it could be an NLP conversation, it could be a contact center conversation, but the conversation is how complex is the decision that you're trying to model, right? On the low end of the complexity, well, if it's a low complex decision, then you have repetitive operational tasks, fair enough, right? And decision complexity is often talked on the same lines as process complexity. Decision complexity, process complexity. If it's a complex decision, it'll be a complex process. If it's simple, repetitive operational tasks, fair enough. If it's high, then you have cognitive decisions, So we often think about repetitive operational tasks and cognitive decisions. But how often in life do you see a single factor across which you have to make decisions? Hardly ever. So I get very anxious when I see a single decision point on which there's a continuous factor of low and high. It doesn't work like that usually. There are multiple other factors using which these decisions have to be thought about. When you think about which model should I build, how many of you have been asked that question, or have you asked that question, should we be building this model or not? Is this a problem or is this a project that we should be picking up to solve or not? What are some of the other aspects that are looked into other than complexity? It's a big enough problem, it's a complex problem, we should solve it. What are some of the other questions that people ask? Do we have enough data? Absolutely. Feasibility, technical feasibility, right? What else? Is the ecosystem ready for it? Will we be able to put it into deployment or not? All right, again, from a technical feasibility standpoint. What else? Value, impact, the return on investment, reliability of the model. Will we be able to build the model itself or not? What are we missing? And I can put all of those dimensions in there. It'll become a multidimensional problem, which it actually is. The point that I'm trying to make is that when we think about which AI to build, we talk about return on investment, we talk about feasibility, we talk about if data is available or not, we talk about will we be able to build the model or not. But do we talk about what is the impact of the decision that we're trying to model? Talk to Ujjwal, knowledge is a key component there. What is the impact of the decision that I'm trying to model? What is the human impact of the model that we're trying to model? If you just look at it from those two dimensions, of course, if the decision complexity is low and the impact of the decision is low, you have repeatable operational tasks. So far, you guys are with me?
When it comes to knowledge, the thing about healthcare and medical knowledge, there's things you know, and things you don't know. There's things you know you don't know, and things you don't know you don't know.
Oh, and that's a very good quadrant as well. And we are so good at making quadrants; they're all there.
Stuff like, I was asking Ravinder the same thing. Over the years, the stuff that you don't know starts to reduce, but there's always this huge chunk of what you don't know in either of those stuff.
Exactly my point, and I'm going to go there. Low and low are repetitive operational tasks where you have a high decision complexity and a high impact of your decision, like diagnosis of disease. Can there be a higher human impact than getting a diagnosis wrong through a machine? You go into cognitive decisions where actual decision making is happening. We still have two boxes of the quadrant empty. Try and think of certain areas where the decision complexity is low, but the impact of decision is high. I call them process-driven judgment. But give me a few examples. Think through this. It's not an easy area. This you might still be able to get to easily. But what are the areas where impact of decisions are low, but the overall, the impact of decisions is high, but the complexity isn't all that much.
It's a surgical safety checklist. I mean, you're saying mobs and stuff, so it's a repetitive action.
Any repetitive action. So surgical checklist is one good example. What are some of the other things that work off of checklists? What about underwriting? What about fraud detection? It's not complex to detect fraud if you're talking about banking. They've been doing it for 30 years. Most of the fraud detection happens at the point of sale machine when you swipe your card. It's rule driven.
Airplane pilots, they go through a checklist.
Yeah, all checklists. So essentially what's happening is there is a process driven judgment. There is a checklist. Whether you're underwriting, whether you're trying to approve a card or not, whether you're trying to pay a claim or not, paying a claim, for example, is a huge checklist, right? You tick off everything makes sense, you pay the claim, it's extremely process-driven judgment. You still got it, you get these things wrong, it still has significant impact. People are still going to worry, or people are not going to be happy if you decline their credit card, if you decline their loan application, if you decline their insurance claim. Low, high. What about this quadrant? Think about decisions that have a low impact but have a high complexity. This is very, very interesting. I want you guys to think through this and come up. You guys are following me so far, right? If there are any questions on this, let me know. This is fairly straightforward. This is the highest end of the spectrum. We just talked about process-driven judgment. Think about processes that are not very complex decisions, or are complex decisions but don't have a lot of impact. What falls here? This is not easy, but it'll come to you. Think about it. Review of literature for a thesis. What does that need? That needs reading skills. Reading is not difficult, but interpreting it, obviously. It's the first thing you need to be able to do is vision. What else? We've all been talking about, you took the example of the cat and dogs, you took that joke away from me, but that's okay. Being able to differentiate a cat and a dog in a picture, do you think that's complex? Does that have an impact on people? What happens if you incorrectly tag a cat as a dog or a dog as a cat? Does it make any difference to anybody? Maybe somebody will not laugh, maybe a few people will laugh. But does it have any difference on anybody? No, it's really low impact. But for a machine, it's a complex decision. Anything that requires human sensory perception to get done falls in this category. Vision, hearing, speech, everything that we've been talking about when it comes to natural language processing, when it comes to computer vision, the things that we are teaching to machines today when it comes to diagnosis or being able to differentiate animals or cars in videos or in pictures are very simple for us because they're sensory in nature. They're complex for the machines, right? All of that sensory determination, it's a determination, it's not even a decision. That's the reason I'm saying it's a low impact decision. There is no decision to be made, really. It's determination. So if you look at it in this manner, if you look at it in like this matrix, then repetitive operational tasks are ripe for automation, robotics, or even very simple VBA SQL-based automation. Process-driven judgments are essentially artificial intelligence with outlier fallouts. What does that mean? Let me go back to a few examples that I talked about. You will always, even if you have all the checklists in the world, we talked about this being driven by checklists, right? Essentially, this is decision basis checklists. You will always run into certain situations where your checklist will not work. Pilots don't always, I mean, they will run into situations where the checklist will not work. Surgeons will find situations where the checklist will not work. The same thing goes for claim adjudicators. You have a checklist for everything. The question is, can we auto-adjudicate 100% of the claims? No. You will always get claims that are so complicated that you will not be able to auto-adjudicate them. Every single checklist-driven operation that you can think of will have fallouts. That's artificial intelligence with outlier fallouts. Sensory determination is pure artificial intelligence. That's what's being talked about when we talk about AI today. Everything and anything related to natural language processing, computer vision, unstructured data, natural language generation. And here, where the impact of the decisions on humans, the human impact of decisions is the highest, and the complexity of the decisions is the highest. If we don't do augmented intelligence, we will never be able to improve the overall adoption of our AI models. Where are we suffering from the deployment of AI models? I go back to the point, 50% of the models make it to production. You can build the best models in the world. At the end of the day, if they don't make business impact for you, they're of no use. Anybody who has spent more than 5 to 7 years working in artificial intelligence and machine learning will tell you that as budding data scientists, while it's extremely exciting to think about and solve for building the best model, unless your model really is able to solve a business problem, nobody will care. And that is how it should be. So today, I'm going to talk about some of the use cases that we at Optum and United Health Group have been able to put into production that really are at that cusp of augmented intelligence. These, I have not included any AI examples that are 100% automated, in which no human intelligence is being used. I've only picked up examples where artificial intelligence is working very well with human doctors, processors, with humans to be able to make the overall process faster, safer, and cheaper. The first one, AI augmented diagnosis. So the previous session obviously was a crash course in terms of how do you do that. So I don't want to get into the technology of whether is it doable or not. It's very much doable. We've seen that. If you have the right quality clinical images, if you have the right amount of annotated data behind you, even if it's small data, the ability to be able to correctly diagnose disease or being able to get to a machine-driven diagnosis is there. But as I said, it's one of the most important decisions that have to be made. Can we leave that to the machines completely in any part of the world, even if regulation is there or not? It would be one of the last areas in which we would basically say that a machine can take an independent decision. I don't see it working like that. I don't think it would. So in our world, in healthcare operations, deep learning convolutional neural network-based applications can get you to 98, 97% accuracy on some of the disease conditions that you see on the screen here. But at the end of the day, it'll be a physician who will be making the determination of whether to approve a prior authorization for that condition or not, basically a diagnosis. Not only because it's a guideline, not only because it's regulation, it's just a decision that I don't think we'll be able to trust to a machine anytime soon, right? I don't want to, yeah, was there a question? Okay, so this is the most often talked about use case. I don't want to spend a lot of time here, we've already talked about this. Let's talk about the application of this from a enhancing the patient experience perspective. I'm sure all of you are, yeah. Sure. Yeah, excellent question. My sister is a surgeon, physician, and the first time she got to know that I'm working on artificial intelligence systems that could help the doctors, she obviously was extremely cynical about it. She was like, you don't know a word about medicine. How can you do something like that? Oh, yeah, well, I don't know anything about medicine. We've got people, we've got doctors on our team who help us with that, right? Initially, it's cynicism. That's where it starts. But once they begin to see the value of it, once there is adoption, what happens is it helps them cut down the time that it takes for them to be able to get to diagnosis. Right, that's value number one. So essentially, if you were making a radiology image-based diagnosis that was taking you 45 minutes earlier, now with the machine learning giving you a 99, a 97, 96% confidence limit on saying that I think this particular diagnosis is true, a doctor can actually spend lesser time in getting to the diagnostic, and the overall accuracy improves as well. But like with every other area, it takes for us to work with them very closely and show them that value for this to really work out.
My question is actually on the other spectrum, in the sense that there are cases in which this can be incorrect too.
Oh, of course, that's why we have a human there.
Right, so that would the physician then get to a point to think that, oh, I anyway got these artificial intelligence system that's going to tell me if it is true or not, and hence make a misdiagnosis. Would we run the risk of that? And is that even happening today?
That's an excellent question. Thankfully, when the doctors make a diagnosis, it's anywhere in the world, they put themselves on the line for a lot of questioning if they get a diagnosis wrong. They would never leave it on the machine. It's just way too risky for them, They, in a lot of instances where we've experimented with this, we've found doctors pointing out the errors that we got in the incorrect recommendation, and we've taken that back actually to be able to make the system operate better. So it's actually working the other way around. But the point that I'm trying to make is that the risk involved in getting a wrong diagnosis would be a big deterrent in something like that happening. How do we enhance patient experience? When people call us, and I'm sure you've seen this experience, let's take a non-healthcare example. When you call up your mobile telephony contact center, do they immediately know what you're calling for? You have to tell them that, I got overbilled. And a lot of times you have to tell them multiple times because they keep transferring your call. And a lot of times you have to wait and wait and wait before your problem can get resolved. What if the contact centers knew that the person who's calling is in need of urgent attention for something extremely important and have the required information available with them that prevents the person to get to a point where he has to call the contact center again? The artificial intelligence aspect of it is pretty straightforward. By looking at members' historical information and everything that I showed to you earlier, we're able to get to a pretty good idea of why would this person be calling us, right? The human intelligence aspect here comes in because the human also has to then determine, working with the machine, that what are some of the additional actions that this person might require for which this person might have to call me back again. That's one of the areas, right? That's one of the areas. But another area is that if we know that this person who's calling us is likely to be suffering from a complex health condition or is in need of specialized care, then we can route that call to specialized practitioners and have them take care of these people rather than treating everybody the same. How would that work for you? If your service provider knew why you were calling, if they knew that this person needs urgent attention in this particular area, and you wouldn't have to explain it to them again and again, and your call was automatically routed to a person who was the best suited to be able to solve that problem for you. That is again a use case that is not possible without man and machine working together. Machine learning determines the reasons why a person might be calling us. The humans work with the machines and the people who are calling them to be able to propose the best solution right then and there, to be able to solve the issue right then and there, improve first call resolution. For those of you who operate in the call center space, I mean, that's how you improve first call resolution, so that people don't have to call you again and again and again for the same problem. It improves the compassion scores for agents. It improves what our members think of us. It helps us get to their queries faster. Yeah.
Have we not reached the stage where you don't have to call the customer care and instead they tell you, you might be requiring this because of your historical claims?
Think about it from a healthcare perspective. Yeah, I mean, that a lot of companies do that today. For example, all the calls that you get that say that, are you sure you don't want a loan? Look, yeah, dude, I'm sure I don't want a loan. You know, my model tells me you want a loan. I mean, that's a completely different thing. What if I get a call from a hospital that says, you know what, I think you need to get admitted?
I understand, but maybe from a prevention standpoint, right?
Excellent question. When we talk about prevention, I did not include that case study in here, but because it again goes back to the previous one that I was talking about. We cannot tell the people that I'm talking to you because you've come up as very high risk on our model. It just freaks people out, understandable. And the first reaction that they would have to a call like that is extreme cynicism. What are you talking about? I'm fit and healthy. I just ran a mile in the morning. The way to go about that is if you know, and in certain cases you would know that a person is at high risk of hospitalization for a musculoskeletal condition or for a cardiac condition, you would try and have them sign up either for a gymnasium that you have a tie-up with, or you would have nurse practitioners call them up and tell them that your name came out in a lucky draw and I'm going to get you some exercise over the next 2 months. All you have to do is work with me for 30 minutes every single day. We do some simple exercises that will get your heart rate up. But you can't tell them that you're acting on a lead that their life might be in danger. It just does not work well in healthcare like that.
So what if I volunteer for a program?
Of course, you can volunteer for a program. You would immediately be able to sign up for a program and your health risks would be ascertained as well. And if there are any programs that we believe might not be suitable for the program that you're signing up for, we'll not let you do that, right? But that happens rarely. Not a lot of people would call up and say, I want to sign up for a program. But the other is how you essentially deal with the question of what do you do if you're able to predict disease. Right.
Now, for example, let's say that I've been going through yearly medical checkups and I know a certain condition, maybe I have a fatty liver. Okay, so that impact will happen, say, a couple of years down the line. That's right. So I'm signing up for a program. There could be hundreds of people who
Yeah,
want to do that.
no artificial intelligence required at all. You're doing great if you're doing that. The problem is how many people actually go through proactive health checkups.
No, I would like them to monitor me on a continuous basis because during the 3 years of COVID, to take an example, one person lost the thing because
Yeah.
that's not good for hospitals.
See, the
And
thing
those are
is,
medical checkups, whatever is required.
if you're going through a proactive health checkup, even in India, I've seen that now, that a lot of hospitals will actually be able to keep the records of their patients who've had health checkups with them over a period of time and be able to show you how you're trending over certain specific parameters, right? So that's there. But I think the trouble is if you're not going through health checkups, how do you intervene then? Right? That's the problem that I was talking about. Yes, you would see this as sensor and wearables. It's a rich source of information, but the person has to sign up and basically say, I consent to let the company use the data. And obviously, any data that gets leveraged has to happen with explicit consent of members, right? So yes, but that's a great point. See, sensor and wearable data is coming up as a tremendous source of wealth of information. I've been leveraging a Fitbit for like 5 years, and I really hope that when the time comes, Fitbit and Google are able to warn me that, you know, buddy, you gotta do something about the changes. But yes, that happens. This is an extremely operational example that I picked up. This is not just healthcare. This is just insurance operations. And I'm hoping this will be applicable in a lot of the areas that you might be familiar with this. So usually what happens, the claim is received when we get a claim for somebody who's had an episode. It goes through manual processing. There is a random audit. We get 1 million claims a day. So obviously nobody is able to audit all of the claims in one go. So you do a random audit. On that basis, the member receives an outcome. Sometimes those outcomes are wrong, and then those members basically report the error, and the entire cycle goes back again. Extremely frustrating because we made an error. What happens if you're able to plug in a predictive model in the process such that the moment the manual processing gets over, your model tells you that there is an 80% likelihood that in this particular case you made an error for every single claim. That's not difficult to do. That's actually a big data problem. There is no manual intervention required till this point in time. So instead of doing a random audit, why would we look at things randomly in today's day and world? We have a team of auditors, human auditors. Why are we throwing things randomly to them when we can tell them here are claims that have a very high likelihood of having an error in them, just because in all of our historical data we've seen that these are the kind of errors that we make. You run the predictive model and then you audit and correct all potential errors instead of sampling. Operational process, not related only to healthcare. Again, a very good example of how machine and humans can work together to improve the overall accuracy of an operation and make sure we don't make errors in our operations, right? Members receive the correct outcome. The issue, this is a piece of work that we actually did years ago. This is what made us begin to think about the whole machine and human paradigm working together, because the initial idea was to not have this. When you talk about the business, was to not have the entire audit piece. When you talk to the business, the immediate question is, what's the return on investment on this? Right? The return on investment in this particular case can be calculated in a lot of different ways. Will I be able to do lesser audits? That's one return on investment, right? Less number of auditors. Another return on investment is, will the overall cost of operation reduce because I'm making lesser errors? Of course, right? But what about the overall improvement, again, in the experience that the member is having with you? How does that part get quantified? So instead of basically saying that we're going to reduce the audit team, we said we'll keep the audit team, but we'll channel the mined claims to them. Think of it as gold mining. Instead of just looking at random soil samples and trying to figure out, will I find gold in here or not, the ability to be able to look at rich ore and send those to your miners and say, well, this is where the gold is. Yeah? This one.
Previously, the market acceptance among those so-called auditors, or if you put it as coders, in their mind, because when you're trying to put a claims cover kind of product to the market, the first thing when it is going to the companies, also the doctors are very welcoming it, the payers are very welcoming it, the providers are also very happy about it. But the coders who are there with the payers or providers, and essentially with providers, they are settled that, okay, probably, although you are catering for the manual processing and you put it in the chain, but somehow that, fear is there.
Run into those situations all the time. The thing that makes a difference here is we haven't actually changed the process from an outside in perspective. The process hasn't changed at all. Actually, think of it like this. This is where the commitment of the error happens. The error gets committed here, using a database terminology of commit. Till you actually send it out of your system, the error hasn't been committed. There is still a chance to be able to correct it. If you're able to correct the error before it gets committed, then nobody outside of your system knows that there was a problem. So from the outside in, there is no problem at all. We are just being able to now correct the claim before it goes out of the system. So it's same day, before the commitment of the error happens. It goes back to the person who committed the error so that he learns from it. And then again, it's only sent out to the member after it's been audited. So that sort of a problem from an outside in perspective does not occur. These guys are happier, the internal coders are happier because now they are getting a much richer sample of claims to be able to work on, right? So there's more job satisfaction from that perspective, which are actually making a difference. Rather than looking at 100 claims and finding one error in them, now you're looking at 100 claims and finding 30 errors in them. Isn't that great? Of course, exactly. And this entire feedback, which was taking months and months because you were letting the errors out of your system, completely cuts down, right? So now you're able to close claims in half the time, sometimes lesser than that, just because you're paying first time right. So like first call resolution in contact centers and claims, it's always first time right. How do you get claims first time right? Right. All right, so repeat call reduction is something that I already touched upon in the previous conversation. If you already know who's calling you through predictive analytics, what are they calling you for? The contact center agents can then work with the members to try and ensure that they get their queries resolved in the very first time. So I see that I just have 9 minutes remaining or so. So we'll just look at what are the summary takeaways that I want you guys to take away from this conversation today. AI deployment needs to be contextualized in terms of its impact on humans. I don't think we do that. The first point that I made, when you ask the question of should we be building a model or not, you would look at return on investment, you would look at feasibility, you would look at data availability. Do you look at what impact will it have, and can we let machines do that independently or not? I think that's an important touch point that needs to happen, not just from an ethics or morality standpoint. The deployment of your model will depend on this. How would you begin to plan on model deployment unless you're extremely clear on will it be an augmented intelligence model or a pure artificial intelligence model? Second point, a successful digital solution will include artificial intelligence, include operations know-how, include robotics, include process know-how. It'll be a combination of all of those factors and not just one single technology. It'll be all of that. I've seen a lot of young, eager, enthusiastic data scientists working day in and day out, just focusing on their code and not necessarily thinking about what will happen to this model when it leaves my workbench. That's a very dangerous approach. Unless you know the business, unless you know how your model will get deployed, there is no value to the business. To take everybody along. And as AI maturity improves, the complex, low-impact decisions will get completely automated. What you saw on the far right here, like everything that requires NLP or computer vision, they'll get completely automate. It's already happening today. But for all critical human decisions, augmented AI will be the most practical approach going forward. So why we all talk about artificial intelligence all the time, I would want you to leave this session keeping in mind that I think the true success will be the symbiosis of artificial and human intelligence working together for the betterment of humanity. That's it. That's us at Optum. I'll open up for questions if you guys still have any more questions. Yeah.
I want to quickly, I think, very insightful presentation, first of all. I think lots to learn. I want to go back to the diagnosis use case. I'm still trying to wrap my head around how is it possible that we reduce the time taken by a doctor to make the decision
I'll
without
give you an
biasing
example.
them?
Yep. There is a condition called blepharotosis. Right? Blepharotosis essentially is when one of your eyes begins to droop, and the clinical diagnosis for blepharotosis can only happen when the eyelid is drooping exactly 2 millimeters below the center of the eye. It's called the MRD1 distance for 2 millimeters. It is that objective. What the doctors get are these facial images of different shapes and sizes, some of them good quality, some of them not. They don't have an objective measure to be able to measure whether the drooping is happening more than 2 millimeters from the center of the eyelid or not, right? But by leveraging computer vision, it is not that difficult to automatically detect a face in an image, figure out where the ears are, where the nose is, where the chin is, and then the usual ratio between these parts of a human face is constant. We know that. Once you have that in place, you can exactly put a measurement grid on top of the face that shows you down to half a millimeter